This is Dr. Hessel dictating the podcast on neuroanatomy. This is meant mainly to be a resource and an atlas for you to refer to at later times. This is a table of contents for this PowerPoint indicating the various slides where these topics are covered. And these are some of the references that I have used. First, I want to talk about the spine and the spinal cord. As you know, there are 33 vertebrae. The cervical spines are rather unique. Some consider the occiput as C0. The atlas has only a ring and no spinous process. The axis has the odontoid process, or dens, which sticks up into the C1. And it's held in place with a transverse ligament. The subaxial vertebrae from C3 to C7 are rather similar and include a body, an anterior pedicle, a transverse process, the posterior pedicle, which is actually the lamina, and upper and lower facets, and a spinous process. A foramen pierces the transverse process and gives passage to the vertebral artery. These features are illustrated in the subsequent slides. This illustrates the important relationship of the dens as it projects into the atlas. The dens is held in place by the transverse ligament. If either due to fracture or ligamentous tear, movement is allowed, it can compress posteriorly into the area where the spinal cord sits. And thus, in radiologic examinations, the distance between the anterior arch and the dens, and between the dens and the posterior arch, are parameters used to detect spinal injury. The first is called the anterior atlantodental interval, or AADI, and this latter is the posterior atlantodental interval, or PADI. On this slide, I have depicted the normal values and the critical values that are thought to be disconcerting and suggestive of spinal injury. There are important ligaments and covering of the spine and the spinal cord, which are relevant not only at times of injury, but also when you're doing central neuraxial block. These are listed going from back to front on this slide and are illustrated in this diagram, starting with the supraspinous, the interspinous, the ligamentum flavum, the posterior longitudinal, and the anterior longitudinal ligaments. This shows the ending of the dural sac, and on the left side and on the right, the dural sac is open to display the nerves. Again, this shows the ending of the spinal cord at about L2 and the ending of the dural sac at about S2. These are reiterated on this slide. The blood supply of the spinal cord is obviously critical and is summarized on this slide. There is the anterior spinal artery, which is a single vessel and supplies most of the spinal cord, and the posterior spinal arteries, of which there are two, which supplies only about a quarter of the spinal cord. These arteries get additional input from the radicular branches, which are located progressively down the spine. This slide illustrates the amount of spinal cord which is supplied by the vessels. Note that the single anterior spinal artery supplies about 2/3 or 3/4 of the cord, mainly the front and lateral, while the posterior arteries, of which there are two, supplies only a small posterior wedge of the spinal cord. The artery of Adamkiewicz is considered by some to be an important blood flow into the spinal cord in the lower thoracic region. Its origin varies, but in about 3/4 of patients, it located somewhere between T10 and T12. The blood flow to the spinal cord is similar to that of the brain and is controlled by the perfusion pressure, the CO2, and the O2. For the spinal cord, however, the perfusion pressure is the mean arterial pressure entering the spinal cord at various levels minus the subarachnoid pressure. This is relevant, of course, during thoracic, aortic, and endovascular thoracic surgery. This slide depicts the various spinal cord tracts, the ascending sensory and the descending motor. The dermatomes refer to the skin supply by spinal nerves and peripheral nerves, and the details are reflected in the next few slides. The sensory nerves of the scalp are important if one is to do nerve blocks for awake neurosurgical procedures. The MYOTOMES refer to the muscles supplied by various spinal and peripheral nerves and are detailed in the next few slides. Let us now turn to the anatomy of the brain. On this slide is shown the surface anatomy from the side. And this slide depicts the names of the various lobes and the major fissures. And on this slide, the names of the various gyri. This is a hemisection of the brain showing its gross internal anatomy. This shows the bones of the skull from the lateral view, including the sutures. This relates the surface anatomy of the lateral skull to the internal brain anatomy, particularly the location of the sylvian fissure and the location of the central sulcus. This depicts the skull from the front and from the side. And this shows a little bit of the internal anatomy of the skull from the back. This is a lateral view of the open skull to depict the important folds of the dura mater, including the falx cerebri, the tentorium cerebelli, and the falx cerebelli. These are related to herniation patterns, which are depicted here. The subfalxion, when the cingulate goes under the falx, the transtentorial, when the uncal portion of the temporal lobe goes through the tentorium, and the foramen magnum, when the cerebellar tonsils herniate through the foramen magnum. This depicts the gross anatomy of the base of the brain. The internal capsule is described on this slide. Importantly, it contains the corticospinal tract, which carries motor information from the primary motor cortex to the lower motor neurons. On these slides are illustrated the course of the internal capsule. The thalamus is a structure that is situated between the cerebral cortex and the midbrain, and has important functions in relaying both sensory and motor signals, and also the regulation of consciousness, sleep, and alertness. It surrounds the third ventricle. And on this section of the brain is illustrated the location of the thalamus below the lateral ventricles and surrounding the third ventricle. The brainstem is described on this slide. It consists of three major components: the midbrain, the pons, and the medulla oblongata, and has multiple important functions as summarized on this slide. These are further expanded on this slide. It plays an important role in the conduction of sensory and motor pathways as the origin of cranial nerves through 3 through 12, and also has integrative function in regards to the cardiovascular system, respiratory control, pain sensitivity, alertness, awakeness, and consciousness. Thus, brainstem damage is very serious and often a life-threatening problem. This section of the brain shows the location of the three components of the brain stem. These are further illustrated on these next few slides. The midbrain is divided into three parts: the tectum, the tegmentum, and the ventral tegmental area. And the location and function of these are described on this slide. The basal ganglia are critical to a variety of functions, including the control of voluntary and involuntary motor movements, learning, habits, eye movements, cognition, and emotion. The main components are listed at the bottom of this slide and depicted in this diagram. This is another lateral depiction showing these basal ganglia. The basal ganglia are relevant in that they are the targets for deep brain stimulation, mainly used at the moment for motor disorders. The most common targets are the subthalamic nucleus, the ventral intermediate nucleus of the thalamus, and the internal segment of the glottis pallidus, as shown on this diagram. This is a 3D depiction of these same structures. The cerebral arteries are obviously essential to the well-being of the brain and are often a site of surgical intervention. Thus, anesthesiologists providing care of these patients need to be familiar with this anatomy. It is arbitrarily divided into two components: the anterior circulation and the posterior circulation. The anterior being supplied by the internal carotid and the posterior by the vertebral arteries and basilar arteries. The cerebral arteries are somewhat different from systemic arteries in that they have only a rudimentary adventitia, and the muscles in the media are oriented circumferentially, which contributes to the appearance of aneurysms. The details of cerebral circulation are depicted in the next few slides. One important component of the cerebral circulation is the circle of Willis. This is made up of one anterior communicating artery, a pair of anterior cerebral arteries a pair of posterior communicating arteries, and a pair of posterior cerebral arteries. It is thought to supply collateral circulation in case one of these structures becomes involved with disease. However, it turns out that it is only totally intact in less than 50% of patients. This is illustrated in diagram A, a complete circle, as I mentioned, present in less than 50%, and then these other patterns. About a quarter of patients have what's called the gerbil circulation, in which there's total separation between the anterior and posterior circulations. This is another illustration of the various patterns that are encountered. On this slide is depicted in sections of the brain showing which vessels supply which part of the brain. And on the next few slides, I have reproduced some cerebral arteriograms. On the left is a lateral, and on the right is a anterior-posterior projection. The cerebral veins are also relevant as a site of both damage and bleeding and thrombosis. These are illustrated in this lateral depiction and named as listed on this slide. This is a horizontal depiction of the veins at the base of the brain. And this is a venogram at the end of an arteriogram. The cerebral ventricles are important, especially in regards to hydrocephalus, commonly encountered in neurologically injured patients. There are two lateral horns, a third ventricle, and a fourth ventricle. Foramen of Monroe, which connects the lateral ventricles to the third, and the aqueduct of Sylvius, which connects the third with the fourth. These are illustrated in the next few slides. The choroid plexus is the site of production of cerebrospinal fluid, and although it is mainly in the third ventricle, it is also in the lateral ventricles and the fourth ventricle. Conversely, the arachnoid granulations, which are extensions from the subarachnoid space, are what returns CSF to the venous system, since they sit inside the superior sagittal sinus. This relates the location of the ventricles to the skull, which is relevant in placing external ventricular drains. The classic landmarks for placing these drains is summarized on this slide. Next, let's briefly discuss the autonomic nervous system. It is basically divided into the central portion and the peripheral portion, and each of these into the sympathetic nervous system and the parasympathetic nervous system. This slide depicts where these various components are located. In more detail are the central organization, and the principal site, of course, is the hypothalamus, but in addition, the brainstem plays an important role. This describes the peripheral component of the sympathetic nerves. The preganglionic, you should take particular attention to where the preganglionic neurons are located, where the preganglionic fibers travel, where the ganglia are located, and where the postganglionic fibers travel. This depicts the details of the peripheral portion of the parasympathetic nervous system, and again, one should note where the preganglionic neurons are located and where the ganglia are located. Finally, there is a unique component called the enteric autonomic nervous system, which is a network of neurons within the walls of the GI tract, including the pancreas and the gallbladder, and they are only under local control. This slide illustrates the location of the primary nerve bodies and the postganglionic nerves and ganglia for both the parasympathetic nervous system on the left side and the sympathetic nervous system on the right side. This slide compares the various types of sympathetic nerves and parasympathetic nerves and illustrates where their primary nerves are located, where the ganglions are located, and where the peripheral distribution occurs. The preganglionic nerve of the sympathetic nervous system, which originate in the spinal cord, exits with the spinal nerves and enters the white ramus into the paraspinal ganglia. It's called the white ramus because the preganglionic nerves are myelinated and hence cause these rami to have a white color. The ganglionic nerve body is located in the ganglia, and the postganglionic nerve then exits via the gray ramus to rejoin the spinal nerve. Since these nerves are unmyelinated, the ramus is gray. Finally, a word about the cranial nerves. These are listed and reviewed in the next few slides, including what their function is, where their origin and target is, and their function, as I mentioned. This shows the exit of the cranial nerves from the base of the brain. And this is a lateral view of the ganglia and, the cranial nerve nuclei and where they exit to become the cranial nerves. And this is a detailed depiction of the distribution of the cranial nerves and their function. The optic nerve, of course, is critical to vision, and this depicts its gross anatomy. The oculomotor nerve has control over the pupil and most of the extraocular muscles, as well as the levator palpebrae, which keeps the eyelid open. It has a very long course and is at risk of compression during hydrocephalus. For this reason, it is an important contributor to the dilated pupil that is often encountered with severe hydrocephalus. This can be both due to compression of the nerve and also compression of the nuclei in the brainstem that controls this nerve. This depicts the course of the oculomotor nerve, its origin in the brainstem, and its relevance to uncal herniation. This is a subtype of transtentorial herniation in which the inner portion of the temporal lobe, called the uncus, is squeezed through the tentorium and applies pressure both on the brainstem and also on the oculomotor nerve, causing the dilated pupil that is encountered in some patients with severe increased intracranial pressure. This shows where the nerve has to go past the tentorium to get to the front of the brain. And that is depicted further in this diagram. And that is the end of this presentation.